All right, let's start. So, welcome everyone to the panel COVID-19, the new reality, which takes place within the 2020 Biotech Atelier. I'm honored to be together with distinguished panelists as Dr. Alexandar Simidchiev. It's very difficult to present him. He's a healthcare evangelist and a digital missionary, but he's also many things. He's an excellent communicator above all, an excellent clinician. We have Thomas Allvin with us, who's Executive Director, Strategy and Healthcare Systems for EFPIA. And we also have Peter Kapitein, who's President and Patient Advocate for a patient organization called, could you help me, Peter, here? What was the name?
Inspire.
Yeah, it's a cancer organization, and it helps patients with cancer turn towards strength and hope rather than refuse to fight, right? Did I put it correctly? So the objective of today's panel is to discuss the new reality, whether we believe it, understand it or not. The world has changed. Just the fact that this is the fourth Biotech Atelier, we have having it fully online without any physical presence shows that, but the world has changed in many other aspects, and I don't think it's going back. So let's discuss today, with the help of the speakers, how we can adapt better to this new reality, what we can do differently, especially in healthcare, so we take the best lessons from this pandemic and don't or deal with the mistakes the COVID-19 pandemic has shown that we have in all healthcare systems, especially in Europe. In the next months or years, even maybe, governments need to understand that prioritizing healthcare is a prescription for prosperity, and how to persuade them doing that in the most effective way probably depends on everyone who's involved in the healthcare sector. So with this, I would like to give the words to Dr. Alexandar Simidchiev for the first presentation in today's panel.
Thank you, Deyan. It's a pleasure to be here, and thank you for the organizers for giving me the possibility to present. My presentation is called, Is the Pandemic the Big Challenge, or is it actually the infodemic? And by infodemic, I mean all the associated communication realities that are aligned to and as a consequence to the pandemic. And if we look at what's happening from an informational perspective, many of the companies that changed so dramatically, and even what you alluded to a minute ago, is that things that weren't changing for decades up to now, suddenly in a very short period of time of several months, changed dramatically. And the implementation lead of all of that was COVID-19 or the coronavirus virus. Obviously, we need to take into account why this happened, and one of the issues I believe is very key in this is the amount of information flow we have, both from the center towards the population and from the population towards the center and between them. And a few years ago, information was shared rather slowly, as was everything else moving slowly. Information is currently being shared much faster in a totally new environment. And I would like to compare it to drinking water. If in the past, the way we were drinking water is like this, slow and taking sips as much as we need. Currently, we're exposed to something like this. We're drinking from a fire hose, which is leading to the fact that we need to be very selective to the amount of information we take in, because information overload can in itself lead to diseases. One of the diseases is called the Dunning-Kruger effect, or the Dunning-Kruger symptom. When we have not enough time, too fast information exchange, lots of info actually, you have a lot of information but little meaning. And because people don't have a lot of meaning, they start believing that they know everything that needs to be known really quickly by getting little information. And then as they get more and more information, they realize that they need to be very selective in what they're doing, because it's not just a matter of having long stilts when you're walking across a deep pond. So with that in mind, I want to switch slightly to the perspective of why we're not managing well with the information flow. And actually, it's a book I read a couple of years back. It's an American book called Wedged Nation. It's about the political system in the States, the Republicans and the Democrats, and why actually a lot of things are not going as well as they could be. One of the reasons is because politicians, in order to differentiate themselves, they take a very skewed or a very lateral position, which, because they're doing that, for example, blue versus red and Democrats versus Republicans, they actually split society into supporting groups, leaving very few people in the middle. And because society is being polarized, communication within that society is being polarized. And it has a very important effect in healthcare, because healthcare is about the shortest critical path between science and the patient experience. So if we want to have the best science informing the patient experience, we need to go through evidence and, of course, care delivery. And if we stretch this out into different aspects, stretching it out with different communication channels, we leave much higher gaps in the middle. And the gaps actually lead to missed opportunities, waste, and harm. So if we want to be really good at managing a pandemic or at managing healthcare, we need to have a very coherent communication strategy so that there's little waste, little harm, and no missed opportunities. But that's not really easy to do, because healthcare is a very complex system where you have on one side things which in Bulgarian we have two words. One is called zdraveopazvane, which means basically healthcare, but actually the two words in themselves is preventing disease or keeping the health. And then on the other hand, we have chronic care, which is not exactly preventing disease. It's about caring for people who are already diseased. In our country, for example, 2/3 of the healthcare budget is dedicated to disease care instead of preventative care. And I don't believe that's much different in many of the developed countries worldwide. But if we think about prevention, it's important because that's the only way we can keep the system as healthy as possible. And if prevention isn't good enough, if the finger is very low, or if it's not close enough, we will get the follow through and all the other people will get sick. So prevention is an extremely important element. To do that, though, we need to have an education system which caters for the whole process, because in order to have good communication within the system, people need to be educated into critical thinking. And so if we think about the people or the pupils, we need to teach them information literacy and how to approach information acquisition and information management. And that includes media literacy, because still the mainstream media are an important element. It also includes digital literacy, because many of us are online. And there's something called transliteracy, which combines all of the different types of literacy in critical thinking, irrespective of where you get your information. We need to battle the misinformation and the disinformation, both of which are leading us aside. So if we think about prevention, we need critical thinking. What about resilience? Well, I would say that resilience cannot be instituted from the outside in. It needs to be family-based. It needs to be within the families. We need to approach this in a different way, where resilience to disinformation or misinformation needs to be bred within the family, not to rely on the schools or the education system. And of course, if we need interventions, we need to specifically think of how we can counter this inherent political element of wedging or dividing the people, so that we have ours versus them, the enemy versus our own people. And this can happen with things we have in hand. For example, if we need to heat up our breakfast in a hotel which doesn't have a restaurant, there's things we can do. And sometimes the practical decisions are actually much better than the original ones which you can buy from a store. So if we think about practical decisions we can do to squeeze out the wedging, the political wedging, there's lots of things which can happen from the bottom up, not from the top down. And I'd just like to share with you a couple of really good campaigns. One is from a commercial campaign. It's extremely well targeted towards the people that require protective activities. And the other one is a non-government organization in Utah, which again made a campaign for managing COVID. But we see that irrespective of whether that's business or whether that's individuals organizing in a non-government organizations, a true belief in what we need to do needs to be there for us to have a good strategy. And the strategy ultimately needs to be something targeted towards the responsibility we have towards our own health and the health of our children and our grandchildren. That was what I wanted to share. I hope it has sparked some thoughts, and I'm open for questions until I'm here, which will be almost 20 minutes from now. Deyan, you're muted.
You're muted.
Yeah. Okay, thank you. I'm sorry. So my question was, should we ask you questions now? Because you have to leave at around 3 and then continue with the rest of presentations. Okay, I have a very quick one. Well, 30 or 40% of Bulgarians do not believe in COVID-19. You were part of the medical expert team who was a part of, leading the communication and doing a lot of things related to the pandemic in Bulgaria. So is this a problem that 30, 40% of Bulgarians don't believe in COVID-19? And if it is a problem, how we can solve it? The examples you showed were actually reaching out to people's emotions rather than the people's minds regarding COVID-19. Can you comment?
Yeah. Two things. First of all, it's not a problem that 30% believe there's no COVID. It's a tragedy. And the reason for that is that when you have such a large proportion of the population not believing in a scientific reality, means that some people still believe in the flat Earth or the fact that vaccines are extremely harmful. All of these issues are an issue of communicating science. And obviously, for many of the people who are not educated into critical thinking, they want to order their world really quickly. And easy solutions where you have an enemy or you have somebody conspiring against you is an important way to manage this. Wedging is, you always need two sides for a wedge. If you're wedging an information, you need somebody who's supporting one side and another person who's supporting another side. And people in the middle have to decide where they want to give their support. And what's happening even in our country now is politicians are taking an opposite view, irrespective of whether they believe or not, just so that they can wedge some of the people away from the other side. It's a sad reality, and it's a sad reality that healthcare is subject to wedging in many countries, and ours including. And the way we can overcome this is through good structured communication, parent communication, managing disinformation at the source. Because once disinformation starts propagating within the social networks, it's too late. The disease has already started inside. So disinformation needs to be managed at the source. And of course, people need to be psychologically vaccinated against disinformation. And I call this psychological vaccination critical thinking. If people are educated in critical thinking from the first grade onwards, there will be a lot of benefit downstream when they get to 18, 20 years old and even later.
Very interesting concept. Psychological vaccination, I like it. Can I use it? Thank you. Any other questions to Dr. Simidchiev from the audience or from the speakers? If not, we can continue. Thank you. Thank you, Dr. Simidchiev. It was a pleasure. Thomas, giving the floor to you, you're engaged in policy making at Brussels level, participating in those processes. And what's the situation there with COVID-19 communication? Is it better than in countries? And what's the feeling there? Do people in Brussels believe in COVID or not?
Thank you so much, and thanks for the invitation to speak. I hope you can see my slides. And I think the belief in COVID in Brussels is fairly high. At least it's what drives most of our work in Brussels. So we have to believe it to work on it. But I think it's a very interesting question, and I think it was a really interesting presentation by Alexander, and I think also I have some of those points also in my presentation. So I just have a few slides on with some thoughts of sort of where health systems need to go, and I think that I first just put down, some lessons learned for European health systems. Of course, the COVID-19 crisis isn't over, but I think we can say some things about how things have worked and what the opportunities are for the future. I think that if we look at the strength, I think that, for all its problems, I think the European health system model kind of works. And if you compare with other regions in the world, I think the sort of solidarity-based, equity-based system that we have, that is sort of the European model, has shown to be a good and fairly resilient one. Public trust, I might have to adjust this. I hadn't heard this figure, 30-40%. Skeptical, but I think at least, and so this might vary, of course, between countries, but I think at least we haven't seen yet the kind of attacks we've seen on kind of regulatory authorities and such things that we have seen in some other countries. I'm not going to name any names. And I think our strong research base when it comes to research and treatment and vaccines is a strong point. I think we've seen a lot of very sudden creativity, an explosion of digital health applications and digital consultations, which last year was like impossible. We can't do this. It's too complicated, and now people have to do it. So it's happening, and I think that's an important point for the future. I think there is some weaknesses. I think we all know them. Systems that are fragmented and very hospital centric they aren't agile enough, and of course in a pandemic you don't want people in the hospital because there they can be infected. So you only want the COVID patients there. So you want the other patients to be treated in an outpatient setting, community care, and for there you need the integrated system to work. And we saw some, I think, unfortunate sudden nationalism in the beginning of the crisis, which maybe wasn't very helpful. Of course, if you have underfunded systems from the start, that's not going to be very resilient. I think we have a lack of comparable data between countries, which is clearly a room for improvement. And I think that comes to the opportunity side, that this is a huge opportunity to really actually make some of the economic recovery we need to do through investing in health and very strategic investments nationally and at EU level on digital health data, and really for once and for all stop seeing healthcare as just a cost. It's an investment for the future, and we need to look at the long-term outcomes, and an opportunity to reform the systems we have. Of course, in the threats we have, cost containment measures. We saw it after the financial crisis. I'll come to that in a second. But we have also, of course, a huge backlog now of other patient groups and diseases that have not been treated. We've seen chemotherapy being postponed, at least in the first phases of the crisis, and this will hit us, next year. I mean, this will impact health outcomes for years to come. And I think we need to be mindful of that. So this is not the moment to cut down on health spending. I think that's very clear. I said that we shouldn't repeat old mistakes, and after the economic and financial crisis in 2008-9, there was a lot of cost containment and across the board cost cutting. And here are some figures from the OECD. The figures aren't that important in detail, but where costs were cut where it's easy to do it for administrative reasons and not with any kind of thinking how it actually impact outcomes. So prevention was very much hit. Also, actually, pharmaceuticals. And of course, all sectors were hit more or less. But I think we need to have a more holistic view to how we spend our healthcare budgets and looking at the future scenarios where we can see, because when we come out of the COVID crisis, we will still have the old problems of an aging population, which is a great thing, but financially can be a problem. And we know that if we have, you can see the red curve, if we have an older aging population that are sort of ill or sick, then the healthcare expenditure will definitely sort of crowd out other expenditure areas and increase much more than GDP. But that also shows that in order to avoid that, we need to spend now to make sure that people stay healthy, because then we can have the green scenario, the green line, where we won't have a problem in the future because we made sure now that they stay healthy. And I think that's an important point to make. I won't dwell much on this. This is just some data on kind of, well, an obvious point. You need to spend to have a population in good health. But I think there's also a lot of unnecessary cost and waste in the system. This is unnecessary hospital admissions because basically primary care and disease management wasn't working for common chronic diseases that you can see, diabetes, asthma, COPD. And if they had been managed through primary care, community care, better patient engagement, then these hospital admissions wouldn't have been necessary to happen. We could have saved a lot of cost and unnecessary suffering for patients. And there is a lot of data OECD has a report on waste in healthcare. I won't go into detail in that, but there are huge savings to be made if you start earlier with screening programs. There's a great screening program for colorectal cancer in the Basque country that both saves money and lives. And this money can then be reinvested into healthcare, into more high value care. But obviously, if you catch cancer patients earlier on, it's much easier and cheaper to treat. So what we should be doing is to take this opportunity to move to more value-based health systems. And you could spend an entire day talking about exactly what value-based healthcare is, and I only have 30 seconds or so. But really to focus the health systems on the outcomes that matter to patients and the costs of delivering those outcomes writ large in the holistic perspective. So for the entire patient pathway from prevention to rehabilitation. And this is really the way that we can combine the different goals of sustainable financing, reducing waste, have patient-centered care. The patient now wants to be sort of in the center also of the decision-making, population health, and also incentivize meaningful innovation. Because in a value-based system, the industry will get the signal on what to invest in that brings the best outcomes for patients. And innovation has already driven healthier lives and resilient societies for many years, will continue to do so, keep people healthy, but also save lives and also keep people in the workforce and make society more resilient. And I think resilience is really the word of the day in the European healthcare debate. And this is a last slide, and this was from an op-ed that the EFPIA DG Natalie Moll wrote in Euractiv on setting an agenda for a new debate on European health systems, and she made a couple of points on we need to finally recognize the social and economic value of health as an investment, not a cost. We need to talk about European solidarity. How can we strengthen health systems all over Europe, because that's for all our good. And the EU now has new funding programs, the EU for Health program, which is much more beefed up. So that's a very positive development. We need to be more integrated in how we fund healthcare, move away from the silos, because then we can make more strategic investments that pay off in the long run. Obviously invest, as I said, in the European health data infrastructure, digital health. We're already doing a lot of things, EFPIA companies through the IMI, public-private partnerships on building European health data infrastructure. Health literacy, to really go back to Alexander's point, clearly everyone, all citizens are now very much involved in health. Patients were already before, everyone is seeking information online. What kind of information are they finding? What can we do to improve the kind of a landscape of health information online to make sure that there are reliable sources that are easily found? And of course, needs of people and patients in the center to really put the outcomes that actually matter for people and patients, because they in the end don't care about how many hospital beds do we have or how many interventions I made, but did I get better? Can I go to work tomorrow? Can I take part in social activities? Can I go golfing? That's the outcome of the surgery or the treatment or whatever it is that they want. And we need to start measuring these outcomes so we can start really benchmarking and learn, have a learning, or these sort of learning health systems, which is this other popular important term, that the kind of data-driven learning health systems that we should strive for in the future. So I think I stop there, but looking forward to discussing this a bit later. Thank you.
Thank you, Thomas. Well, what you're saying is on top of the usual increase of demand for treatment, which we have in Europe, that's aging population demands, we will have a backlog of untreated patients from this year moved to the next year, and we'll probably have additional costs due to the pandemic, and all these things will pile up. On the other hand, what we see is an economic slowdown. And how does it look from Brussels? Are European governments prepared to invest more in healthcare next year, or just the opposite? Because of the economic slowdown, less investments in healthcare, and bigger problems. And when you said integrated approach to funding healthcare, did you mean more EU into healthcare than we have now, or something different?
I think, yeah, so it's a good question. I think the first question, I think that I think that the European Commission and in Brussels it is realized that we need to kind of invest ourselves out of this, and the Commission has put a very ambitious recovery and resilience program on the table, the Next Generation EU, where they also boosted the EU health program to really help member states strengthen health systems. Then the member states and the council came in and they took down the budget a little bit, or quite a lot. So there's this huge tension. But I think I think it's a bit early to say exactly how the member states would work. But I think that there's definitely an awareness of this, I would say, in Brussels, and there will be a close monitoring of how this recovery and resilience is working in the different member states, which I think is really good, and I think we really need to work together, all the kind of stakeholders in the sector, to really talk to our politicians in different countries and say, hey, cutting costs now would be a recipe for disaster down the line. So don't do that. I think when it comes to integrated budget, I was more talking about at the national or even regional level, and in the sense that as long as you have a budget for pharmaceuticals, for medical devices, a hospital as this budget, the primary care clinic, and everything is split up. then you can't really invest in these things that affect the entire pathway. And if you have an intervention here that saves money in a hospital, that you can't make use of that if it's not the same budget. So you don't have the investment you don't have the incentive to invest, for instance, in prevention, because you will not reap the savings of that investment. So I think we need to think more about incentives and what are the right incentives for doing the right thing from the beginning, and not just sort of kicking the can down the road to someone else's problem.
Okay, I understand. When you want to build a house, you need a joint budget. You don't have separate budgets for painting and roof and everything. Yeah. So it should be, integrated, the approach to that. All right, I guess we can take more questions later. Peter, well, what's the new reality for oncology patients in Europe after COVID-19? Can you help us better understand that?
Yes, a short introduction of myself. I'm a patient advocate and founder of Inspire to Live. And it's always good to keep in mind that I'm talking always about cancer. So the things that I bring up are related to cancer, the consequences of cancer. I was diagnosed with a lymphoma myself in 2005, had excellent care for many years until 2009, when I survived in the end with because of 2 bone marrow transplants from a lymphoma. So I know the value of care, I know the value of science, and I saw some terrible things happen in the past 6 months, not only in the Netherlands, but I think all around the globe. And it's interesting that the CEO of the Erasmus Medical Center, one of the big academic centers here in the Netherlands, gave an assignment to a well-known consultancy agency in end of May, which was more or less the end of the first period of COVID-19 in the Netherlands. And the conclusions of that report are quite astonishing. There were approximately 15,000 healthy life years gained by the measures taken here in the Netherlands for COVID-19. But there was a lot of collateral damage in regular care. Approximately 250,000 healthy life years were lost because of the measures taken. So imagine a gain of approximately 15,000 healthy life years and a loss of 250,000 approximately. And these are astonishing. They are terrible figures when you are a cancer patient. And not, again, I am a cancer patient. That's the reason why I talk about cancer, but it's also exactly the same for quite some other serious diseases. During that period, you saw that the cost of care were rising with approximately 40%. So when we started here in the Netherlands with the first day of the lockdown, which was March 13th, I immediately said to a couple of friends of mine, you can't do this without extreme consequences. And my background is, my employer is the Central Bank of the Netherlands, so I work with hundreds of economists, and we all know that the fundament of healthcare is the economy. And we also know that when there is an economic crisis, the consequence for the vulnerable people, mostly low-educated people, low-income people, are much higher than for the higher incomes. And there is a study in 2016 published in The Lancet about the consequences of the economic crisis of 2008-2009. And only for cancer, they estimated that there were 265,000 more deaths of cancer because of that economic crisis. So like I said, you can't take these measures like lockdowns, etc., without consequences. That is not a conclusion to not do a lockdown, but you have to be aware that if you focus on one aspect, it has consequences for others as well. Well, to give some figures, we know that here in the Netherlands, and it's probably the same in other countries in Europe, that there was 40% less revenue on melanoma medicines in the second quarter of 2019. 40% less medicines for melanoma means cancer patients with metastases, which means that they will probably have, well, hopefully they will not all die, but the consequences will be extreme. There were in the Netherlands in Q2, in second quarter, 5,000 less diagnoses. The consequences of that will be exactly the same. There will be patients, lots of patients, hundreds, maybe more than thousands of patients that will die because of a later diagnosis. Cancer patients are frightened to go to the hospitals because they all know that in hospitals normally there are a lot of bacteria and viruses that are in hospitals. That's why people go to a hospital, because they're sick. I had my most extreme infection caused in a hospital. So that's the consequence of going to a hospital. But cancer patients were afraid to go to the hospital, though on one way, because of the hospital, tell the patients stay home for a couple of weeks, couple of months. On the other hand, it were the patients themselves that were frightened to go to the hospital. So that adds up. The consequences were great. But what could you do about it? In that same report by Gupta Strategists consultancy group here in the Netherlands, they advised to do more. You could say more e-health. More visits by patients via video, because there were done a lot of visits by patients by video. Well, that was of course already, it was possible before COVID-19. And a lot of hospitals said, no, we can't do video consultancies because of all those reasons. And suddenly COVID-19 made it clear that it can be done. So it could be done. There were a lot of objections against it, and COVID-19 caused it was done. And quite often it's very good to have these video consultancies because it saves travel. It saves a lot of time, of course, for patients, but also saves a lot of time for physicians. So I think that is one thing that can be done. Of course, lifestyle interventions. Quite often I say to people, the best prevention for COVID-19 is a healthy lifestyle. Because we know that there are two groups vulnerable: the people with underlying illnesses, mostly caused by obesity or smoking, and elderly people. Well, you can't do anything about growing old, but you can do something about your lifestyle. So the best prevention is probably a good lifestyle. And I think there is a role for governments. And a lot of governments are now saying, yes, it is very important to do prevention, to do a lot about our lifestyle. We will see what happens when COVID-19 is behind us. Normally, you should say, normally we have a lot of good ideas when we are in a crisis, because people talk a lot about change, but people really do not want to change. They only change when there is an urgency. Well, COVID-19 is an urgency, so now we want to change. But if we're going back to normal, well, the urgency is forgotten quite fast. So are governments prepared to invest in healthy lifestyles? Because there are probably a lot of costs up front, but a lot of gains in the mid or long term. So that's it. There is also a good advice. I think that we should concentrate the care for COVID-19 or other viruses that will come in next year or the years after, etc. That we should concentrate the care for that in, you say, special hospitals. You could call it virus hospitals or so, but so that you can continue the normal care for patients in the hospitals that they are visiting normally. There is one hospital in the Netherlands who is only there for cancer patients, which is the Dutch Cancer Institute, and that continued their care pretty normal. Yes, with of course measures to beware that people do not enter the hospital with COVID-19, but the treatments were quite normal, were normal as they were in the past. And I think that it's in the presentation of Thomas, there was that patient-centric patient participation element, and I think that's very important. But mostly patient participation is not really participation. It's hear what they say and then continue business as usual. So I think that when decisions are made, I mean, a lot of decisions in the whole COVID-19 crisis are made by, of course, by politicians, but based on virologists' opinions. And here in the Netherlands, it was only in May, so quite late, that they also brought in people with other backgrounds, for example, economists. I mean, we estimated that in our growth, in our economy, the costs were approximately 2.3 billion euros a week. Well, you can imagine what the consequences of that are. So if you bring in different perspectives in the decision, what should we do? You get a better balanced idea of the consequences and what should be. And I think that bringing in patients in that, we call it an outbreak management team, which is pretty odd because the outbreak was 6 months ago. But if you bring in patients in that decision-making governance structure, you get a better balanced decision what is wise to do. And of course, I have my opinion on that, but that is not of interest for this moment. But we all know that if you have a decision based on different perspective, different opinion from different specialists, the quality of your decisions and the output of your decision will improve by that. So I think that let hope drives that. Let hope drives the future that we make a better group that governs the second wave or the next virus that will be more pandemic than we had in the past, etc. So that the group that we've made is more balanced and can make better decisions to improve the quality of life of citizens and patients in special. That's it.
Thank you, Peter. So what I hear is that regardless what happens with the next wave or waves of the pandemic, access of patients to treatment shouldn't be limited or delayed because the costs of that might be greater than the pandemic itself. And it's about for us to see in the next year or two what the real cost of the measures taken was. I read recently this report of the Bill Gates and Melinda Gates Foundation, which said that healthcare went maybe 20 years back, losing the progress achieved in the last years due to that pandemic. And I hope that the numbers are not so severe in Europe, but still, we'll see in the next years the progress achieved, how it was lost, and how important healthcare was. To my opinion, at least in Bulgaria, I've witnessed that until now, the problem of the patient was its own patient. The society didn't care so much about the patients individually, but the COVID made the whole society involved in the problems of the healthcare system. We were patients all together, regardless whether we got it or not. We lived through the whole, still living through the whole thing. And I think people now understand how important healthcare is. And you shouldn't delay treatment, even if it comes through a video conference. I know that doctors are very resistant and they say that nothing can replace the physical contact, but in some cases it can. In some cases. And we have to find a way how the system reimburses even doctors for their efforts, even when they have a video contact with the patient, because we know that this is one of the concerns they're having. Okay, I was told.
One remark, because I like your expression about that. Normally, I say the difference between a patient and a citizen is urgency. Mm-hmm. Normally, in normal situations, citizens have no urgency, and for that reason, they do not care really for healthcare. But COVID-19 took care of the urgency so that all the citizens know the value of healthcare.
Exactly. You're exactly right. So I was stalling a little bit with the agenda because we didn't have our fourth panelist online, but now we have him, Mr. Evgeniev. We know each other for a long time. Currently, he's a research attaché at the permanent representation of Bulgaria to the EU. He joined a little later, but I hope that he'll be available to give us a bit of his view on the new reality after COVID-19 and how the EU research agenda, and in this case Bulgaria too, can be adopted to meet that challenge and to that new reality. Evgeni, are you online?
Can you hear me now? Hi, thank you very much for this introduction, and good afternoon to everyone. Indeed, I was a little bit late with the entry to the panel, but I heard Mr. Kapitein, and I agree with most of the observations he had. So from my position as a research attaché for Bulgaria here in Brussels, I wanted to touch base on couple of important issues that came along with the coronavirus pandemic. First of all, how did the European Commission react to the coronavirus pandemic? And second perspective, what did the European member states did to make a substantial contribution, bringing Europe in the lead, in fact, in fighting the coronavirus pandemic. So what I can share from the outset is very fresh information for everybody in this panel and speakers and the listening participants, that we have so far a package for Horizon Europe, the next framework program for research and innovation, that will be operational between 2021 and 2027 with the budget proposed at this stage, because we have a couple of more months to negotiate under the multi-annual financial framework program. We have a budget of close to 90 billion euro. And what I can say is, for the health package, for the so-called health cluster, there is a dedicated budget of close to 7 billion euro. And of course, because of the coronavirus pandemic, the innovation aspect and the research aspects, especially related to health, research has remained very important, and it's high on the agenda of the European Union. So we have a preservation of the package of close to 7 billion, as I mentioned, but we also have a new instrument called Next Generation EU, which provides a total of 5 billion euro extra money to this package, Horizon Europe, to finance primarily health-related issues, including COVID research. So what I wanted to mention at the outset is that the European Commission has been very active since March in working closely with the member states to provide a short-term action plan that would fight the COVID pandemic. And what this action plan jointly created with the member states, and Bulgaria was one of the active participants as well, is that this action plan brought a total of 10 areas that were called priority actions for coordinated research and innovation actions. And I think it's important to mention all these areas. Number one, this is the coordination of R&I funding against the coronavirus, which brings together all the health researchers of the EU and uses the potential of everybody in the European Union and beyond. The second priority action deals with the extending and supporting large EU-wide clinical trials for clinical management of coronavirus patients. And what we have discovered is one of the networks in Europe. Probably some of the panelists know about that or participate in that action, but particularly led by France. This action brings together a lot of West European partners for European-wide clinical trials. And what we try to incorporate in this action is that we bring also peripheral countries into that action. So we have the involvement of the East and the West of the European Union. The number 3 priority action deals with the funding for innovative and health-related approaches to respond to coronavirus and deliver quick results. This includes also medical technologies and ICT applications, health system preparedness. So there is a new funding window that started immediately, actually, even before the whole union was engaged. At the end of January, the European Commission started to fund projects related to preparedness of health systems. Increasing support to innovative companies is the priority action 4, which brings the new financial instrument under the European Innovation Council. This is the so-called Innovative Europe instruments that provide risk financing. So there have been 2,000 of applications provided by innovative companies from all over Europe, and several hundred were funded already. Over 200 were funded under the new COVID crisis response. The priority action number 5 deals with opportunities for other funding sources for SMEs and startups to provide under the structural funds managing authorities. So these are operational programs under structural funds in all European Union member states for R&I actions on coronavirus. And number 6 priority action deals with the development of a one-stop shop, and we already have this so-called ERA, European Research Area Corona platform, which is available for health researchers all over Europe, also for businesses. And number 7 is a priority action that brought together experts under high-level R&I task force on the coronavirus. And in fact, between March and May, there were 5 working groups, representatives of businesses, representatives of research institutes and ministries that came together from all over Europe to discuss different aspects of the response measures of the European Union. And one of these aspects was the clinical trials. Another one that was discussed on the separate working group was the manufacturing aspect. The third aspect related to the financing. So that's called for priority action 7, whereas priority action 8 deals with access to research infrastructures, where we have opened in all over European Union opportunities for health researchers to collaborate and use research infrastructures, analytical facilities, biological samples, pathogen labs, regulatory support, social science research infrastructures. Number 9 is the sharing research data platform, which is part of the European Open Science Cloud, which is a new initiative that has been there for about 2 years now, that brings together data and access to data for innovative and research activities in European Union, which relates to data, models, workflows, and results. And finally, the priority action 10 deals with the European initiatives like hackathons, which were successfully organized in May. At the beginning of May, we had a hackathon that brought together thousands of entrepreneurs from all over Europe. And at that time, Estonia was in the lead for this hackathon. But then at the end of May, we had a matching facility which brought together in one platform all these successful entrepreneurs that won rewards, including Bulgarian teams, I would say, were some of the winners, and brought them together with funding sources. So all over, in fact, it was in early May, and donor funding window closed at the end of June, when the European Union in the lead with President von Leyen actually brought together a lot of funding sources from all over the world to bring 17 billion euro for new treatment, vaccines, and diagnostics. In that respect, the European Union became one of the global leaders, if not lead actor in bringing together global support. So what I can mention from the Brussels perspective at the end of my intervention, I'm happy to get into the discussion afterwards, is that the European Commission, in close partnership with the member states, managed to co-create a program that brought together researchers from all over Europe, businesses, successful businesses, who work together on a common platform to fight against the coronavirus pandemic. And in addition to that, there were several initiatives, including the initiatives for innovative medicine, that again has a funding window from the European Union that was very successfully working, opening calls for big consortia of businesses and health institutes and universities to work on successful treatments, diagnostics, and vaccines to fight the COVID crisis. In that respect, I believe the current situation has proved that there is a possibility to coordinate efforts to strengthen cooperation of health systems in the European Union, but also present opportunities for innovative companies to get funding for innovative solutions that bring better opportunities to fight successfully against the coronavirus pandemic. Thank you, Deyan. Back to you.
Thank you, Evgeni, for this insight in the European Commission's efforts to create or help create the right innovation ecosystem, which hopefully will come up with results in the fight against COVID-19, and the sooner the better, because COVID-19 is not a challenge for any organization to face alone, neither a company or a state or even the Commission. So the joint efforts of authorities, the Commission, member states, industry, hopefully will produce quick results, which we're all expecting. So I'm told that we have to be very sharp at ending at 3:30 p.m. So we have 3 minutes to take questions from the audience, if there are any. They can transfer the questions only in written. Okay, so there are no questions. So we have maybe a minute or two for any closing remarks. If you want to add something, Thomas, Peter. If not, well, I can conclude then. It has been a very interesting discussion, at least for me, a lot of takeout. And what's the most important thing, I think, for me out of this discussion is that if until now the healthcare urgency was their individual perspective of the patient and his family, COVID-19 made it so that the healthcare urgency is already a healthcare urgency for the whole society. And people across Europe and politicians across Europe understand that urgency and are prepared to act on it. Hopefully this will help even in economic slowdown, as we're witnessing now. And the acts on that urgency will not only face the pandemic threat, but also the usual threats any healthcare system in Europe is facing, because they're very serious. And by delaying treatment there, we might cause more trouble than the pandemic does. And prioritizing healthcare is really a matter of the prescription for prosperity, and more people understand that and are ready to act on it. So with this, I can close the panel, and I think the next panel is in 15 minutes. Mr. Dmitry Manolov will lead that, and it will be related to keynotes regarding COVID-19. So Thomas, Peter, Evgeni, thank you so much for participating in this panel, and hope it was useful for you too. Thanks.
My pleasure.
Thank you so much. It's a great discussion. Thank you.
Thank you.